Welcome back to Lesson 8, Part 2, Anxiety and Some Miscellanea. I'm going to start off here with a little bit of humor.
Oh, this is great. This is what I need, just what I need. Okay, take it easy. I'm sure it's nothing. Probably rats on the track. They're stopping for rats. God, it's so crowded. How could there be so many people? This guy really smells. Doesn't anyone use deodorant in the city? What is so hard? You take the cap off, you roll it on. I feel something rubbing against me. Such disgusting animals. These people should be in a cage. We are in a cage. What if I miss the wedding? I got the ring. What do? You can't get married without a ring. Oh, I can't breathe. I feel faint. Okay, take it easy. It'll start moving soon. Think about people in concentration camps, what they went through. And the hostages. What would you do if you were a hostage? Think about that. This is nothing. No, it's not nothing. It's something. It's a nightmare. Help me. Move it. Come on, move it. Wait, why isn't it moving? What could go wrong with a train? It's on tracks. There's no traffic. How could a train get stuck? Step on the gas. What could it be? You think the conductor would explain it to us? I'm sorry, there's a delay. We'll be moving in 5 minutes. I want to hear a voice. What's that on my leg? Why couldn't I take a cab? For $6, my whole life could have changed. What is that on my leg? I'll never.
Feel free to watch the rest of the video on your own. It is one of the classic Seinfeld episodes. And by no means, please do not interpret this as making fun of people who have anxiety or panic attacks. A couple of thoughts. Because of this actress's great facial expressions and her really vivid personification of anxiety in a anxiety-provoking situation, I think it just kind of gives us the sense, and if you watch it, you can actually kind of feel her heart racing, the sweat forming, and all of the various somatic symptoms that go along with anxiety, which are so sometimes very crippling. I also want to kind of use this as an illustration of a way that you can kind of normalize the anxiety response. It is a normal response, that heightened hyperactivity, ready for fight or flight. And so anxiety isn't necessarily always bad, and it's important to keep in mind as we work with our patients. So let's go talk a little bit about assessment. Again, we're not an assessment course, but again, there is another tool. I'll have you take a look at this one, the GAD-7, 7-item anxiety rating tool. It has been validated. There is an article to support that here. And this particular tool, again, similar to the PHQ-9, is helpful in not only identifying whether the person has true anxiety, generalized anxiety disorder, or in fact, may have a combination of that and depression, and also help them to look at their symptom management over time with the various treatments that we might employ. Pathology, getting back to the neurotransmitter piece and kind of reflecting on that business of the GABA, the gamma-aminobutyric acid, serotonin, dopamine, and epinephrine all involved, but GABA is the major inhibitory neurotransmitter, as we discussed, and that is going to be the one that we want to have in place and help us out. It has been found in some research that there is intrinsically a lowering or a less amount of GABA in some persons, and also some structural things that are found in some people with anxiety. Looking at MRI scans, the amygdala, very highly sensitive to new or unfamiliar situation, reacting with a very high stress response. And again, in that silly video, here is poor Elaine reacting quite severely to the situation, and the people around her seem so very blasé, like you would expect in a New York subway. So our treatment decision making, very similar to depression treatment. We want to really bring a person to a point of feeling like they're able to function and to get through life. Certainly anxiety does occur, but that they're able to function. So non-pharm treatment is the mainstay. It is the first line. CBT, cognitive behavioral therapy, being #1 treatment. Now, pharmacologically, SSRIs are our #1 choice. We've already talked a lot about those, and we would use similar dosing regimens as we do with major depressive disorder, starting low and titrating up slowly. But the SSRIs are our #1 effect. Of course, it's really important to stress with this patient population especially that this drug, the SSRI, is not going to work quickly. It's not an instant cure, and that they may need to use some other kind of rescue medicines once in a while or as an overlap when they begin their SSRI. You'll see many protocols that look at starting a benzodiazepine, which, as you recall from our neuro discussion last week, that's going to help more GABA be present because there's a binding to the GABA subunit of the GABA A receptor. So the use of benzodiazepines, both for overlapping at the beginning of treatment as well as rescue medications as we move along, is appropriate. Of course, they're problematic because of their habituation tendency. And of course, in this case, we don't really want to use very short-acting like alprazolam, which is Xanax. We don't want to use the short-acting medication as we bring the person into the SSRI. We want to use something fairly moderate or long-acting to avoid dependence and to quickly move them into the SSRI for the treatment plan. So what's an alternative to benzos for kind of a rescue medicine? Because that is important. You still need to have something on hand. One of the ones I tend to use quite a bit, I believe it is off-label. It's an old antihistamine, an histamine 1 blocker. It's supposed that the mechanism of action for anxiety has to do not only with its sedating effect, which is particularly sedating drug, but there's some modest serotonin 2 receptor antagonism in addition to the histamine response and muscarinic blocking effects. Again, it has a lot of anticholinergic side effect, not surprising because of the muscarinic block and the antihistamine, dry mouth, etc. But does work. Very, very sedating. I usually start with 25 milligrams. They can take it every 4 to 6 hours, and they can use up to 50 milligrams in that time frame. And it's also, sometimes I have people start with a half a pill and see how that works. And I do have them try it first at home where they can sit down or lay down if needed because some people get knocked over with this medication. Another alternative that I'm not personally familiar with very much is the alpha agonist clonidine. I know that folks in mental health will be familiar with this. It stimulates the alpha-2 adrenergic receptors. It is a centrally acting antihypertensive medication, so of course someone with lower blood pressure we have to be careful. But the anti-anxiety effects of clonidine appear to result from its actions on the receptors which decrease the noradrenergic activity and kind of calm down things altogether. It's an interesting drug used for lots of things: pain mediation, induction of anesthesia. It's all over the place. For this use, we give 0.1 milligrams or 1/10 of a milligram twice daily in the oral form, or if they can afford a patch, the 0.1 milligram patch is put on and changed weekly. And of course, side effects have to do with antihypertensive effects as well. A quick drive-by on a few of the things about antipsychotics and ADHD. Again, I would emphasize these are not medications generally prescribed initially by primary care providers, but we will be watching people and we will have consultations. I'm going to touch in a minute on some key points about antipsychotics in terms of mostly their side effects, because we're not going to be prescribing them for the effect, but we're going to be watching for side effect and adverse reactions. We have kind of two groups of antipsychotics, typical and atypical. The typical being the older ones, such as haloperidol, Haldol being kind of the classic, and then the atypical drugs, which really have been miraculous. ADHD treatment, primary care, again, We're very careful in primary care about the stimulants, which are the older drugs, and very, very effective. And please do not interpret this as a slam against stimulants. They have saved so many people from not being able to function, including younger patients as well as older. They do, of course, have an abuse potential. They are habituating, and they do have a street value, so we have to be really careful to monitor the use of these drugs. Non-stimulants such as Strattera, boosting norepinephrine, thought to be its mechanism of action in increasing attention, a little less worrisome in terms of the addiction. Again, in my practice per se, I do not start patients on these medications, but certainly do monitor them. And with stimulants, I'm monitoring particularly the weight of younger patients to be sure they're maintaining their weight, because they will lose weight. Again, stimulants have been used as weight reduction medications, understandably. This is a quick little cartoon that helps us understand a little bit about schizophrenia and the treatment for what we call positive symptoms, funny word, but the positive symptoms of like the paranoia and the hallucinations, etc., suffered by our folks with schizophrenia. And untreated, the D2, dopamine 2 particularly, are responsible for moving through the synapse and stimulating these positive effects. We then give D2 antagonists to reduce these effects. And you can see how those work from the cartoon. However, as with many drugs that have such a potent effect, we also have a very narrow threshold or line between where the antipsychotic works and where the side effects of EPS, which we're going to talk about in a minute, and hyperprolactinemia, which I'm not going to talk about here, but certainly has effects in terms of fertility and other male issues. So again, one of the worst forms of EPS is tardive dyskinesia. It is one that is not reversible. We'll talk about some of the more reversible ones in a minute. This, because of the blockage of the D2 receptors in the pathway for dopamine, there's an upregulation of the receptors, and therefore we get these symptoms of tardive dyskinesia. And in a minute, I'll lead you to some videos that will help you understand what I mean by this. So classically, the EPS, or extrapyramidal symptoms, I'm probably pronouncing that incorrectly, has been applied to typical antipsychotic medications, but we do see it with atypicals. And also, that article that I gave you for suggested reading, which is very interesting, many GI medications can cause these EPS effects. And again, there are reversible effects as well as non-reversible. Again, from the article, you'll recall that they say that it's neuroleptic, literally, from the seize the neuron, the Latin seize the neuron. So these two videos give you a sense of what we see with some of the EPS side effects. Again, these are treated with an anticholinergic, interestingly, cogentin, not particularly effectively, by the way, as you will read in some sources. But this can happen. We can see people come in actually on other medications that are related to the antipsychotics, and we see them walk into ER and they're actually having one of these severe reactions, and we have to reverse it with medication. So please watch these videos. They're very telling, certainly very sad in terms of some of the effects that can occur with patients who are on these very important medications. And you can see why people want to go off their medications when they have these side effects. So that's the end of this video. I thank you for your attention and time.